Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 345 of our pharmacotherapy series, entitled Care of the Critically Ill Adult. The next case reads, PAK is a 76-year-old male admitted to the medical ICU for likely sepsis from a urinary source. He was acidotic on arrival to the emergency department and intubated. He has a past medical history of hypertension, diabetes, multiple pulmonary embolisms, several urinary tract infections, and reports drinking 10 to 12 beers per day. His home medications include metoprolol XL 100 mg daily, metformin 1000 mg twice daily, atorvastatin 20 mg daily, lisinopril 20 mg daily, and warfarin 7.5 mg daily. Labs on arrival are sodium levels of 131 milliequivalents per liter, K 3.2 milliequivalents per liter, BUN 33 mg per deciliter, serum creatinine of 2.7 mg per deciliter, hematocrit of 20%, platelets of 47 × 10⁻³ per microliter, and an INR of 5.9. What risk factors does PAK have that would qualify him for stress ulcer prophylaxis? Several risk factors have been identified to help determine who should get stress ulcer prophylaxis. Cook et al. Investigated 2,252 ICU patients and found that there were two major risk factors for clinically important GI bleeding. 1. Mechanical ventilation for more than 48 hours, odds ratio 15.6, and 2. Coagulopathy, odds ratio 4.3, defined as a platelet count of 1.5 or a partial thromboplastin time of greater than 2 times the control value. Other risk factors that have been identified include head injury, burn involving greater than 35% of body surface area, partial hepatectomy, hepatic or renal transplantation, multiple trauma with injury severity score of greater than 16, spinal cord injury, hepatic failure, history of gastric ulceration or bleeding during year before admission, and 2 or more of the following. Sepsis, length of ICU stay longer than 1 week, occult bleeding for at least 6 days, and administration of high-dose corticosteroids, greater than 250 mg per day of hydrocortisone or equivalent. Most clinicians will start stress ulcer prophylaxis in patients who have equal to or greater than one major risk factor. For patients who have multiple minor risk factors or patient groups excluded from major trials, spinal cord injury, traumatic brain injury, or thermal injury, stress ulcer prophylaxis is determined by the primary team on a case-by-case basis. PAK has a major risk factor in that he is likely to be intubated for at least 48 hours. For this reason, he should be started on stress ulcer prophylaxis. The next question reads, What medication could be initiated in PAK to reduce his chance of developing a stress ulcer? The mechanisms to pharmacologically prevent against stress ulcers are to layer the gastric lining with a protective coating, lowering the gastric pH by neutralizing gastric acid secretions, or by preventing gastric acid secretion. The three classes of medications used for stress ulcer prophylaxis are histamine 2 receptor antagonists, H2 blockers, proton pump inhibitors, abbreviated as PPIs, and protective barrier-producing medications. A fourth class of medication, prostaglandin analogues, have been used for stress ulcer prophylaxis in the past, but it has not been shown to be beneficial and will not be discussed in this chapter further. After deciding to start stress ulcer prophylaxis, the next decision to make is what agent to use. The two most commonly used classes of medications are H2 blockers and proton pump inhibitors. H2 blockers were found to be superior to antacids and sucralfate in two different trials. There has been a plethora of research comparing proton pump inhibitors to H2 blockers, but there still lacks a consensus on what agent to use based on conflicting data. A recent meta-analysis in over 35,000 ICU patients showed H2 blockers had a lower risk of GI hemorrhage compared to proton pump inhibitors, that is 6% versus 2%. Adjusted OR, 2.24. With a 95% confidence interval of 1.81 to 2.76. This differed with a previous meta-analysis of 13 randomized trials showing reduced GI bleeding in the proton pump inhibitor prophylaxis group compared to the H2 blocker group, that is 1.3% versus 6.6%. OR, 0.30. With a 95% confidence interval of 0.17 to 0.54. A meta-analysis of 14 trials and 1,720 patients found that proton pump inhibitors reduced clinically important upper gastrointestinal bleeding and overt upper gastrointestinal bleeding compared to H2 blockers. An area of debate is whether a patient who is receiving full caloric supplementation through tube feeds requires pharmacologic stress ulcer prophylaxis. Enteral nutrition has been shown to increase gastric pH to above 3.5 more often than H2 blockers or proton pump inhibitors. Animal models have shown a protective benefit of alimentation on the gastric mucosa from stress-related damage. The practice of whether to discontinue pharmacologic stress ulcer prophylaxis if enteral nutrition has been started varies among different institutions. The next question reads, are there any adverse effects associated with placing PAK on stress ulcer prophylaxis? While pharmacologic stress ulcer prophylaxis has shown to decrease bleeding events, it appears this does not come without risk. Gastric acid plays an important part in sterilizing the upper gastrointestinal tract, and alterations of physiologic pH have shown adverse effects. The higher pH level allows increased colonization of potentially pathogenic bacteria in the gastrointestinal tract. After the implementation of stress ulcer prophylaxis as a standard of care in ICUs, several studies and meta-analyses identified an increased risk of nosocomial pneumonia and Clostridioides difficile infections in patients receiving H2 blockers or proton pump inhibitors. The increased pH levels as a result of these medications have been proposed as a mechanism of action. Available data are conflicting on the incidence of nosocomial pneumonia among the agents that alter gastric pH. Two studies showed an increased risk for H2 blockers compared to those who did not receive acid suppressive therapy or sucralfate. One meta-analysis showed no difference on the incidence of nosocomial pneumonia when comparing proton pump inhibitors to H2 blockers. A recent study showed that proton pump inhibitors had a higher incidence of pneumonia compared to H2 blockers. Both proton pump inhibitors and H2 blockers have been associated with an increased risk of Clostridioides difficile infection. Most of these studies are observational and did not control for comorbidities, so there is still much debate in the critical care community. While sucralfate does not alter gastric pH, it can interfere with the absorption of many medications including ciprofloxacin, phenytoin, digoxin, and levothyroxine. To help prevent this, sucralfate should be given 2 hours after these medications. Sucralfate has been shown to bind to tube feeds and cause bezoars and cannot be given through duodenal or jejunostomy feeding tubes. There are several options of stress ulcer prophylaxis for PAK. A proton pump inhibitor or H2 blocker would be the best choice. Since he is intubated and does not have a feeding tube yet, an IV H2 blocker such as famotidine, renally dosed, or IV proton pump inhibitor such as pantoprazole would be appropriate. The next case reads, TDM is a 74-year-old female admitted to the medical ICU for pneumonia and a COPD exacerbation. Her past medical history includes hypertension, hyperlipidemia, and COPD. On the first day of her ICU stay, she decompensates and develops respiratory failure requiring intubation. Among other laboratory abnormalities, her blood glucose concentration is 212 mg per deciliter. So my question reads, how should clinicians manage TDM's hyperglycemia? A variety of biochemical mediators, such as cortisol, glucagon, catecholamines, and growth factor, may rise in critical illness and contribute to hyperglycemia by increasing glycogenolysis and decreasing gluconeogenesis. In addition to the effects of critical illness, inadequately treated diabetes, adverse effects of drugs like corticosteroids, and exposure to caloric loads from nutritional regimens or dextrose used as a base for intravenous solutions can contribute to hyperglycemia. Although studies suggest that hyperglycemia of critical illness is associated with poor outcomes, it is not clear whether hyperglycemia leads to worsened outcomes or if it is simply an indicator of disease severity. In addition to the magnitude of hyperglycemia, glycemic variability has also been associated with negative outcomes. The optimal blood glucose range for critically ill patients has not been definitely established. Uncontrolled hyperglycemia has the potential to cause severe effects. Single-center studies of surgical and medical ICU patients treated with intensive insulin therapy to achieve blood glucose concentrations between 80 and 110 mg per deciliter initially suggested improved outcomes, but these findings have not been replicated in subsequent trials. In fact, some studies have suggested that aggressive insulin therapy may increase mortality as compared to liberal blood glucose control, typically targeting 140 to 180 mg per deciliter. It has been suggested that the higher rates of hypoglycemia observed in patients receiving intensive insulin may increase mortality by leading to neurologic complications. On the basis of these findings, most clinicians attempt to maintain patients' blood glucose concentrations between 140 and 180 mg per deciliter. Since parenteral administration of insulin achieves more rapid and reliable results than oral therapy, patients are typically managed with subcutaneous insulin or intravenous insulin infusions while in the ICU. Subcutaneous regimens typically include as-needed sliding-scale insulin involving rapid or short-acting formulations. Scheduled long-acting insulin may be combined with sliding scales in some patients. However, clinicians should cautiously dose insulin in order to avoid hypoglycemia. Some patients with significant insulin needs may benefit from a continuous intravenous infusion of regular insulin that is carefully titrated to the blood glucose goal. Since TDM's blood glucose exceeds 180 mg per deciliter, clinicians should attempt to achieve better glycemic control. First, dextrose-containing fluids should be minimized, and any enteral nutrition she is receiving should be evaluated. Medications, like steroids, that might increase her blood glucose concentrations should be assessed and minimized as possible. If her blood glucose remains high after these measures, it would be appropriate to initially consider sliding-scale insulin with regular insulin. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 346.